All right, thank you for joining us today for our surprise billing webinar. There's been a lot going on and we wanted to really talk you through it. For those of you who have joined our past surprise billing advocacy town halls, the last one was in August. All of those are still available on acep.org if you want to kind of look back and see how far we've come. So on the federal level, surprise billing has been an ACEP priority for the last 2 years, building on many more years than that at the state level, where ACEP and many of our chapters have been very active trying to address surprise billing or out-of-network balance billing issues that come up at the state level. But starting about 2 years ago, this became a big issue at the federal level. And so at the federal level, what have we been highlighting our advocacy on? Most importantly, we try to emphasize the unique aspects of emergency medicine, including the EMTALA obligations that require you to provide treatment regardless of coverage, which has a big impact on insurance coverage and a lot of the dynamics there. We've also focused on protecting patients' access to care and avoiding unintended consequences to that. And then we've been advocating for an independent dispute resolution approach. There are several states that use sort of varying IDR approaches, and we've been advocating for something closest to the New York one, but as things have evolved at the federal level, it's not quite the same, but that's the main baseball style IDR approach. But so what else have we done as part of this advocacy? We actually, ACEP leaders and staff have met with more than 1,000 have had over 1,000 meetings with federal policymakers and their staff. 2 national ad campaigns have garnered millions of impressions. We've had dozens of op-eds placed, and we've helped all of you advocates write hundreds of letters to the editors. And then most importantly, we have come up with our groups through our grassroots systems. We have spearheaded more than 50,000 messages that have gone to Congress. Those have been the most important, and that's something we hear about all the time from congressional offices when they talk about our messages. We've also created 2 digital campaigns which garner millions of impressions. One of these is Protect Emergency Care, and that provides a deep dive for policymakers and staff on our preferred legislative approach and some of the benefits of that, and that's at protectemergencycare.org. And then there's our Out of the Middle website, outofthemiddle.org, which is aimed at patients and is kind of an umbrella organization for 9 other medical specialties that we've done a lot of our advocacy with. Next slide. So I mentioned our previous one in terms of our previous town hall that was in August, but what's happened since? And all these efforts that we've talked about previously with the 1,000 of meetings, the 50,000 emails, you might wonder why all that was necessary. Why has this taken 2 years? And that's because from the beginning, there has been a ton of misinformation on this issue that's out there. Some of it intentional, some of it unintentional. So we have had to do a lot of education. I talked about how we've been emphasizing the importance of EMTALA, but we've had to do a lot of education around that and really just correct a lot of this misinformation at the federal level. This was a new issue at the time to a lot of members of Congress and their staff. And so we had to do a lot of education and really counter some of those negative ads and ensure information. So since August, you can see here, this is highlighting some of our activity since then, and it covers kind of the range of different types of activity. We have done a lot of grassroots. That goes back to the 50,000 messages to the Hill I talked about earlier. We have placed op-eds in newspapers and healthcare periodicals. And we've done a lot of letters to Congress, either jointly with our 9 specialty coalition partners in the Out of the Middle coalition, and then as well on our own. And all of these are on acep.org if you want to check out our timeline of surprise billing activity over the last 2 years. So here are also some examples of some of the things we've placed, the consumer messaging, as well as messaging to our own members to take action, to tell Congress they need to act. You can see the out of the middle advertising. That's a Facebook ad that we had for consumers, as well as an op-ed with former ACEP president Fedor Friedman. So where are we now? The current landscape on surprise billing has been underway. And we're just gonna hold 1 second to make sure I have the right slides. We had earlier this summer, the House Energy and Commerce put out a proposal that was HR 3630. And that was something that ACEP opposed. It caps out-of-network reimbursement at median in-network rates. It's strict, originally it was strict benchmarking, but then they added an IDR option, but they set it at a really high threshold. Only claims over an allowed amount, not a charge, an allowed amount of $1,250 would meet the criteria for arbitration. So most emergency claims would not be eligible. And then the House Education and Labor proposal, which I just mentioned, is being marked up today. That is pretty similar to the Energy and Commerce one, but it includes an IDR option, but with a lower threshold. We also had the Senate Help proposal, which really is pretty disruptive to the healthcare system. That has a hard benchmark, no IDR at all. So it would really significantly distort future contract prices between physicians and insurers. So that was definitely concerning. Right before the holidays, Energy and Commerce and Senate Help, so two of the proposals we really didn't like that we had opposed, came together and merged their bills into what they called a compromise proposal. Wasn't much of a compromise because they pretty much agreed with each other, but they came together with one proposal. And we had to do a lot of last minute grassroots and advocacy that you all were really helpful on to stop that. That was really supposed to go to a vote in the year-end fiscal package that would keep the government open. And so there was a lot of weight behind it, but in the face of a lot of opposition from physician groups and others, we were able to slow it down. And that allowed Ways and Means to bring their proposal into the mix. They put out kind of a summary of it right before the end of the year, and that slowed things down on that combined proposal. So that's kind of where we are now. These are the four proposals that come from committees, so are currently under consideration in Congress. There were a couple other proposals you probably heard about, especially from us, and that's one that was led by Congressman Raul Ruiz, an emergency physician from California, and Dr. Phil Rowe from Tennessee. And they had a bill that was very similar to the New York state model, but because that doesn't come from a committee, and because there were some issues with how it is scored congressionally as part of the budget process, it really wasn't able to be considered by the committees, despite a lot of sponsors that ACEP and other advocates were able to get on. But aspects of that bill have been pulled into some of these other proposals that you see. Similarly, Dr. Bill Cassidy in the Senate had his own approach. He had a work group of 5 other senators. It's bipartisan, and they came up with a bill. And same thing, without being a committee product, while pieces of it have been folded into the Senate Help proposal, it's not really under serious consideration on its own right now. So that's kind of why we're not talking about it. So just a couple hours ago, I mentioned that Education and Labor was marking up their bill that we definitely have concerns with. That's got that threshold of $750 of allowed amount. So that's the in-network contracted rate. Even though that's better than that original $1,250, we created this map to show members of Congress which level 5 emergency codes in the Fair Health database would even qualify for that $750 threshold. So you can see very few geographical regions would qualify. And this is actually, we've heard a lot of good feedback on the Hill that this has been impactful and really, I think, kind of demonstrates what parts of the country would definitely be hit differently than others, and just how few areas there are that can access this process. So I mentioned the Ways and Means bill, which came out, they put out the summary at the end of the year, and actual legislative text, everybody has been waiting a long time for, came out just last week on Friday. And we reviewed it really closely, and we took a close look at it, and with a lot of factors weighing in on this decision by ACEP leadership, decided that we should support the bill with some qualifiers, but ACEP did officially weigh in supporting. We put out a statement to the media last night. So I think a lot of people are probably wondering, why are we supporting? How does this bill work? So a couple of different details about it. It uses IDR, but it has no thresholds. So that's different than some of the other proposals you just saw a couple slides ago. It does allow physicians to batch claims if they are going to IDR. So that reduces their administrative burden, which is particularly important for some of our smaller practices who really don't have the back office staff to deal with this. It sets emergency deductibles at the same rate for patients as if they're out of network as if they were in network. And that's really important because a lot of emergency care remains unpaid by patients because they have such high deductibles, especially out of network deductibles. So by having their out of network emergency deductible, be the same as if it were in network care, the insurer will start to pick up more of the tab, and that means more likely reimbursement for emergency physicians. So that was something we had pushed hard to have included in legislation. It also requires the insurance companies to print the patient's deductible on their insurance card. A lot of people choose their insurance coverage, when they do even have a choice, based on the monthly premiums, and they don't really understand what that deductible means, which leaves a lot of, again, unpaid care, and a lot of surprise bills are actually just a result of a high deductible. It has nothing to do with out-of-network or in-network status. So we think that'll be an important patient education and transparency tool to help people understand the limitations of their insurance coverage. Another question we've heard a lot about is, how does this work in terms of if your state already has a law on balance billing? So what it comes down to for this particular proposal is that if your state already has an existing balance billing law, that will continue to apply to your state regulated insurance plan. So whatever the state is regulating now that your law applies to, will continue to be subject to that law. Your state's law will not right now apply to ERISA plans or employer self-funded plans. This new bill would. So whatever is passed by Congress will definitely apply to those ERISA plans. If your state does not have any balance billing law, then both your state regulated and ERISA plans would be subject to this new method that this new law would have. So that's kind of the difference. So your state regulated plans will not be preempted by this bill if you already have an existing law. If you do not, they will. So I know that's an important consideration for a lot of folks. Another part of this bill that folks have asked about is any requirements placed on emergency departments on the facility side and hospitals that are in the legislation will also apply to freestanding emergency departments, whether they're independent or hospital owned, regardless of that. And then it does include an IDR process. Before the IDR process, it has this 30-day open negotiation that can be initiated when the physician gets their payment from the insurer. So the out-of-network physician submits a claim to the insurance company. The insurance company sends a payment. If the physician is unhappy with that payment, then they can trigger this open negotiation process for 30 days. If they're still not happy by the end of that process, then it goes into an IDR with an outside mediator that both parties can choose together. That mediator has to be independent, things like that. It's baseball style IDR, and then loser pays. So that's kind of the standard approach. What it does rely on is the arbiter can look at the median in-network rate for that service and for that plan in that geographic area. But then also the IDR, the arbiter, the IDR entity is required to look at any other pieces of information that either party brings to the mediation process, except for charges. That's the only thing that cannot be brought. And so people keep asking why we would support a bill that doesn't include charges. And that's obviously a really valid question that was previously ACEP's position at the state level. But because of the way congressional scoring works, whenever you have draft legislation, the Congressional Budget Office will score it and basically calculate the cost to the federal government or to the economy of the legislation. And because they work with limited information, they score kind of an absence of information as costing a lot of money because it's kind of the worst case scenario. And so because of that, anything based on charges, which are set solely by the physician and have no really upper bounds, I mean, we know that there are market forces, but just from a CBO economist perspective, there's no upper bounds. Because of that, the scoring is really high. And so some of these, that proposal from Drs. Ruiz and Rowe would have scored at costing, I believe, over $20 billion. Whereas some of the other proposals save upwards of $20 billion. So that's a $40 billion delta there. And that's made it really hard for us to be able to have Congress introduce legislation and seriously consider legislation with our preferred approach because it just can't pass the CBO test. It's not fair, and CBO is something members of Congress have complained about for years. They've introduced their own bills to fix CBO, but it's just kind of a reality, and it's one that we have to operate in, and we really have no choice about that. So having the IDR entity look at the median in-network rate has kept the score reasonable. And so that's one of the reasons the Ways and Means bill includes that. We are still working to see if we can change some of that language, at minimum, make sure that full consideration is given to the other pieces of information the physician might bring to arbitration so that the median in-network doesn't have too strong an influence on it. Shortly before the bill was introduced, the original bill actually had, instead of median in-network, it required the arbiter to only rule within 80 to 120% of the median in-network. So due to significant advocacy by ACEP and others, we were able to get that change to the current approach. So just to give you kind of a framework of what we're able to make changes in, this is sort of as good as we've been able to get. So it does still need some work though, like I said. We're trying to change that median in-network. It includes language that points to the insurer being required to pay the physician upfront before any mediation is started. But the language is vague enough that I know there's a lot of folks that are concerned about down the road somehow that being used as a loophole or exploited. So we're trying to strengthen that language to make sure it's clear that the insurer must pay, and we're even trying to get a time frame within which the insurer has to make a payment to the physician. They did make a change to include assignment of benefits to the provider. So that's that really will take the patient out of the middle and ensure that providers are reimbursed for the care they provided and won't have to chase down patients through collections as much as previously. So like I said, it still needs some work, but it's the best path forward. You saw the 4 proposals on the screen that are under serious consideration. There are no others. It's Ways and Means that we've been waiting on as the last one. And Congress wants to move really quickly on this. They wanted to have this done by end of December. The provider community, physicians, and hospitals were able to slow it down. But now they are facing a May deadline because that's when the next fiscal renewal authorization has to be passed by. And so all of this has to be done in their eyes by May 22nd, if not sooner. They'd love to do this sooner. And so this is an issue. It's been 2 years. It's taken up a lot more time in Congress than I think they expected. They heard about surprise bills from constituents. They thought, okay, great, we're going to fix this. And they had no idea what they were in for or how complicated it was. The insurance companies have done a really good job of putting a lot of misinformation out there and putting a lot of money into lobbying for their preferred approach, which is really just strict benchmarking to the median in-network. And so we've been able to counter that to some extent, but we will never be able to get charges like I talked about just because of the scoring limitations. So it is the best path forward right now, or the only path forward, and for the foreseeable future. We think something will be passed by Congress just because of that strong motivation. They're going into an election year, so they want to be able to go back home and tell their constituents what they did to help on healthcare. Healthcare keeps rating is like the biggest concern that voters have. It was in the last election. Some of the Iowa caucus and other initial polling is still showing that holds true. So there's a lot of motivation for Congress to pass something. So something, even if we're to fully oppose and try to kill this, I think there's really little chance we'd be successful. If we somehow were successful, looking ahead, members of Congress will continue to hear from constituents who are getting huge surprise bills. Deductibles are continuing to go up, so that'll just happen even more. And when they go to return to this issue next year, they're not going to be happy that they weren't able to do it, in part because of opposition from the provider community. They're not going to start with a clean slate. Why would they? There's tons of information from 2 years of this debate. So they'll just go right back to looking at approaches that are somewhere around median in network. So our assessment was that Ways and Means presents the best path forward. It helps mitigate some of the damage that a strict benchmarking proposal and even some of these others with thresholds would create to emergency access to care and to your livelihood as emergency physicians if passed, which they were very likely to pass. So our hope is that we can continue to make some incremental improvements to the Ways and Means bill. By supporting it, that gives further opportunity for the Ways and Means bill to have enough legitimacy to have improvements made to it. Without that, it would have just been education and labor in the House and energy and commerce, which were pretty similar. And then those weren't too different from what was in the Senate. And so that's 3 out of 4, and that sounds good. So let's call it a day. So we're trying to keep Ways and Means alive so that it can be improved. Committee staff has so far been good to work with on this. They have reasonable, thoughtful approach. This is very well written legislation just from a technical perspective. So we're hopeful that can continue to move forward. But we have the markup of that bill is tomorrow, the Ways and Means proposal. In addition to ACEP supporting it, so far from what I've heard, the American Osteopathic Association has, the American Hospital Association, Federation of American Hospitals, and AAMC, the academic medical centers. I'm sure there are others. This is just what we've gathered over the last few hours. So we hope to see a lot more groups and state medical associations jump on and support this so that we can all continue to improve it together. So with that, I think we're going to open it up to questions. If you have questions, you can use the Q&A feature on your screen to submit that in writing. Let's see what comes up. Yes. Sure. Taking a look. So how concerned is ACEP about the considerations for arbitration? What's the strategy here, particularly with the significant risk that median rates are considered? Any thought to including median contracted rate from the provider perspective? So we are definitely concerned about median in-network rate having too strong an influence on the decisions made by the arbiter. We're trying to strengthen, at minimum, strengthen the language to expand, to make sure that the arbiter looks at median in-network and any other information the physician brings to arbitration equally. So we really want to make sure that that's strengthened. In terms of, and other specialties are weighing in similarly with that concern. I would say that's the biggest one. Unfortunately, the limitation is that the further away from median in-network that we go, the higher the score of the bill. So we keep kind of bumping into that. There is some room for Ways and Means to still make changes without having the bill cost money overall, but I think they do still, leadership probably does want to use some of the savings from that for other healthcare programs, which is sort of how it works on the back end here in Congress on healthcare issues. So in terms of including the median contracted rate from the provider's perspective instead of just the insurance perspective, the bill, what it does is the bill during the open negotiation process, the 30-day process, it requires both the physician and the insurance company to share their own median contracted either payment or charge, depending on which party you are. And so that's definitely raised some concerns. That's a lot more transparency than I think previously has been in the system. That information stays between those two parties, and the idea in terms of Ways and Means from committee staff, the idea of this section was that everyone brings to the table the median so they kind of know where things stand. But that's definitely one that folks have raised some concerns about. We're trying to get a little more clarity on how that would work. It is just part of the open negotiation, so it's not binding, but just having that information shared, I know is concerning to some of the folks we've heard from. So looking at another, is there any chance to make the benchmark a % of fair health is a question. So we were told that one of the lead committee folks involved in this did not want to use any type of database where possible. So that's why there's no benchmarking to a database in the bill. We definitely advocated strongly for fair health to be used. I think they allow for use of a database in parts of the bill when there isn't enough information from either the physician or the insurance company on median contracted rates, for example, but it doesn't go beyond that. And as much as we tried to get that added, we have been shut down on that angle. Another question I see is, what is the barrier to continued year-to-year downward spiral of reimbursement if we use median in reimbursement for IDR? That's a good question. The concern, for those who are less close to all this, the concern with using a median in-network year over year is that as plans start to drop their more expensive contracts, that median is artificially lowered in future years, and then year over year, that'll continue to happen until you basically spiral down. The Ways and Means bill benchmarks to a past year. Right now they have it at 2019. We definitely heard stories of insurance companies dropping contracts in 2019 as surprise billing legislation heated up that benchmarked to 2019. That was already in draft form in June. And so we know those rates were already being gamed. They have additional language in there that actually protects against that. They use only the maximum payment the insurer made in 2019 to calculate that median in network. This is getting kind of complicated, sorry. So on a technical level, if they did drop contracts, they're still held to whatever they were paying, let's say in January before they dropped contracts. The median is calculated off that. That's a little overly complicated, and who knows what they were able to do in the first part of the year. So we're actually calling strongly for them to benchmark it to 2018 instead of 2019, and just don't worry about all this maximum and calculating the technical difficulties. And so by having that to a past year, they've added annual increases based on CPIU, Consumer Price Index Urban, for annual updates for the first 5 to 6 years. And then they'll do what's called a rebasing, which is where they kind of check where things are and then readjust that, because you don't always want to just do year over year CPIU on healthcare things over, let's say, a decade. It usually will start to skew things and have a bad impact. So the bill does address that concern, whether it's sufficient or whether it'll work. Obviously, I think that's a little harder to know for sure, but they certainly were aware of that concern and found it legitimate enough that they included provisions to address it. Just looking, sorry.
Yeah, I know there's a lot.
So one question is, are you able to speak to the effect on California, given that we already have a balanced billing law in place? So I should start with that I do federal government relations, not state. So I am not the expert on this, but in all my discussions with our California chapter and some of our California advocates, my understanding is the California law, at least the one that's currently being talked about, does not apply to emergency physicians, but the impact on other specialties is being felt, and we definitely are using that as an example of what would happen if they went through with that type of approach, just median in-network benchmarking at the federal level. So we are definitely talking about that. One question says, main issue we see is allowing insurers to drive down their in-network rates, which we've been talking about. Can we even trust the insurance companies to be honest about their in-network rates? I think that's a great question. And again, something that the committee clearly thought was a legitimate concern, and they included provisions in there that subject the insurer to audits. I believe it'd be by the Department of Labor. They would do regular spot checking audits. They would only audit a certain number of plans per year, every month, but they do have that if a physician or even patient feels that this is inaccurate, they can make a complaint. And then if an insurance company, if there's a complaint against an insurance company, they must be audited then. So while there's spot checks just kind of randomly going on, if there's a complaint, it is actually investigated. So hopefully that will, and then I think there's pretty heavy fines if they find any dishonesty by the insurance company. So hopefully that will help kind of encourage the insurance companies to be honest about this. I know that a lot of the legislation, there's sections of the legislation that ensure that everything is calculated using only commercial insurance plans. So this should not include Medicaid or Medicare Advantage. I know we're looking through the language to make sure there aren't any loopholes there. So if somebody finds one, I'm not saying it's 100% solid yet, but I think certainly committee staff, when we talked to them, expressed their intention was to have this only be based on commercial insurance. So hold on, looking through the questions here. So a lot of questions around the same theme, which kind of shows how much of a concern all of this is. What happens when insurance companies drop all the groups who have a negotiated rate above the median in-network rate? Additionally, how widespread is the geographical region? What would happen if a group dropped if an insurance company, dropped all the groups who have a negotiated rate above the median in-network? For the purposes of this bill, it wouldn't matter. It would not help the insurance company because this is still based off of whether it's 2019 or 2018. We're still waiting to see how that plays out. Let's say it's 2018. This will be based on their median in-network in 2018 with annual increases for inflation. So dropping groups does not help them. And if anything, dropping groups will probably not be to their advantage. There is some language in the bill, I believe, calling for study of network adequacy. Does not include any provisions to strengthen network adequacy, even though we've asked for them. But dropping provider contracts will not help them change that median in network that's used in arbitration because that's set to a prior year. How have the insurance companies reacted to the Ways and Means bill? Somewhat quietly so far. There is a coalition to stop surprise bills, or I don't remember their exact name, And they include some consumer groups and the association that represents the ERISA health plans, so the employers, and some large employers who self-fund. And they put out a statement of opposition, which kind of goes to show you that that must mean it's somewhat provider friendly, because they have always been on the opposite side of that. But from the larger associations, Blue Cross Blue Shield Association or AHIP, America's Health Insurance Plans, who represent some of the for-profit insurers, the United, Cignas, Aetnas, they've so far been quiet. So this might kind of signal that if everybody's either quiet or supporting with only a couple outliers opposing, maybe this means that from Congress's perspective, they've hit or getting closer to a sweet spot in order to resolve this. What is the likelihood of the Ways and Means bill passing? For it to pass as it currently is on its own is pretty slim. What's going to happen is it should pass out of committee tomorrow, and then it needs to be reconciled somehow with the other products in the House, with what I presume will pass out of Education and Labor today, and the Energy and Commerce proposal that we talked about that passed this summer. So those will have to be somehow merged and reconciled, and we expect House leadership to play a big part in that. Included in that negotiation, most likely, will be other things that are priorities for House leadership, including drug pricing. So it's going to become kind of a piece of a bigger puzzle. But I think the likelihood of something passing is high. While ACEP has supported this Ways and Means bill, as it goes through the process and starts to be merged with the other proposals, should more of the things we're concerned about be added to it, we would not, it doesn't mean we'd automatically keep supporting. We're not locked in by any means. If the changes are made to a bill and the changes are bad, we can withdraw our support, and that's pretty much expected at that point. So we're keeping an eye on those changes, and we'll continue to make decisions and assessments of whether we should continue to support, or down the road, whether we would stay silent, or if we'd even have to oppose on a final kind of bill that comes to the floor of Congress. This will call for payments to count towards the in-network deductible. It's allowed 2 deductibles. So someone asked a question, does the proposed Ways and Means bill call for out-of-network payments to count towards the in-network deductible, in other words, 1 deductible, or does it allow 2 deductibles of equal size that must be satisfied before insurance kicks in? On the emergency side, it's 1 deductible, essentially. There's been some last-minute changes in the language that we asked for. We still have to confirm that all of them were made, but my understanding from the changes I saw is that they have changed the definition of cost sharing, which previously through the ACA and other existing statute was just co-payments and co-insurance, to now be co-payments, co-insurance, and deductible. And for patients who receive emergency care, cost sharing is the same, whether it's in or out of network. That cost sharing should now include the deductible. So that's one of the positives that we've seen. So when talking with legislators, should we focus on opposing the other 3 bills and explaining why they are harmful, or should we rally support for the Ways and Means bill at this time? So I would say you can do a little bit of both. We are going to be putting out a grassroots alert later today that hopefully you all will receive and take action on, and you'll see that we are kind of encouraging support for the Ways and Means bills, plus noting some of the improvements that we're looking to make. But we're also going to continue to focus on our concern about a threshold. So I guess the one nice thing about the other bills is that they all have some kind of threshold at this point, other than the Senate Help Bill. So you don't have to specify what the problem is with each of those 3 bills. You can just say any surprise billing legislation, in order for us to be able to support it, has to include an IDR process, and that IDR process should be accessible without any threshold. And that basically addresses all of the other bills and expresses concerns with those. And we'll talk a little bit more about how you can take action once we finish with the questions. So have there been any support from other medical surgical specialties that are taking call? and will balance billing legislation impact current call arrangements? So most of the ones I've checked in on are still trying to decide what their final official position will be, but I've definitely heard from quite a few of them that you know, their take on the Ways and Means bill is that this is a really big improvement, and they're just seeing if they can officially support or not as part of their own internal kind of process for that. We have worked with these specialties that take call on a lot of this. That's part of our Out of the Middle coalition. We did a lot of group sign-on letters throughout the last 2 years to Congress on this issue with specific shared asks. So we are definitely continuing to talk to them and trying to stay together as one voice on this issue, because I think that's pretty important. Looking at a couple other questions, and then we'll switch to how you can take action. What can we do to help push the Ways and Means bill? Which legislators are best to target? Once we get out of the markup tomorrow, it will really just be the rest of the House being best to target. We want to get co-sponsors on that bill. We want them to understand why that approach is better and why the others with the threshold are bad. So it'll be a pretty broad target. Obviously, leadership offices are definitely key. But overall, just the more members of Congress on the House side that hear about this, the better. I will do one more, couple questions about how is the average in-network rate calculated? Is it a weighted average? Sorry, I'm reading a lot of math. I don't think they get as detailed in terms of weighted averages like this, but they do account for volume, I think was the concern on the question. So some of this methodology will be fleshed out in the regulatory process, which if whatever legislation is passed, the regulation that's then written is almost more important than the legislation itself, because we saw with the ACA and the greatest of 3 rule how differently a regulation can implement what we thought was the intent of the legislators. So I think some of those details will be fleshed out in the regulatory phase, which doesn't mean they don't matter. It just means that we will have to fight that fight at that time. So, all right, so in terms of how you can take action, so we have a bunch of materials on acep.org that you can access. We have our toolkit that's in the middle there, the Surprise Billing Federal Advocacy Toolkit, which includes some of our graphics. Like we have that one on the left that explains the baseball style IDR process. As things were happening in Congress, I talked about all the education we had to do. Some of the insurance companies and the employers were going out there and saying that IDR in New York, for example, costs $10,000 for each claim and takes forever and requires lawyers. So we had to educate them on how it actually works. In New York, by the way, it's essentially done online. It does not require lawyers. It does not cost $5,000. I think it's $200 to $300 if you lose and have to pay for the arbitration process. And so that's in the materials. We've got some fact sheets and talking points. We're continually updating those. So if you downloaded the toolkit a few months ago, definitely check back for our most up-to-date talking points. It looks kind of the same on the cover, but the messages inside have evolved. And then we also will be adding that national map I showed you earlier in the presentation, as well as we now have, for any of the states on that map that had yellow in them, I think it's 7 or 8 of them, we have state level maps as well that we'll be adding to the toolkit, since I think the offices in those states, the congressional offices in those states, will find those especially helpful. Last question that we had that I forgot to address, but is, will this be an issue at LAC? So LAC is at the end of April. The kind of extenders package that I was talking about that Congress wants to include this in expires May 22nd. So there is a very good chance we'll be talking about this at LAC, but Congress is also trying to, we are told that Congress is trying to fast track this and might, for probably the first time ever, pass extenders package early. And so there is a chance that it will be done by LIC, but I would say it's much more likely that this will still be an issue. We know the AMA is in the middle of their version of LIC right now and had to do a lot of last minute adjustments to all their messaging and materials because of the bill that just came out on Friday. So we sympathize with their staff right now. So that's how you can take action. We hope that this has been helpful. We're going to keep updating folks along the way. We've tried to stay in touch with a lot of our advocates, our chapters, both the execs and the leaders and their lobbyists, and really want to get everyone going. You can join the ACEP 911 network, which is under acep.org. If you go, I think it's in the Federal Advocacy Overview, which is in the upper bar. There's a Get Involved link, and you can sign up for the 911 network. If you do that, you will get weekly updates on what's happening in Congress and in CMS and the administration, not just on surprise billing, we promise. And then you'll also receive our grassroots alert to take action and help weigh in with Congress, both on surprise billing and other important issues for ACEP. In terms of all member alerts, you probably saw we sent out an update to all our members on surprise billing last week. We've sent out a few alerts to take action to all our members, not just those in the 911 network, and that helped us in December kind of stop that momentum and stop a bad bill from being passed before the end of the year. So we may be reaching out to all of our members at some point in the next month or two to kind of continue that fight and hopefully be able to support something. But if things get too kind of damaging for emergency medicine, we might call on you to push back or to oppose. So with that, thank you everyone for joining us today, and you'll receive an email later today with how you can take action, and we hope you'll weigh in with Congress and make your voices heard. For those who are only able to join for part of it, this was recorded, so we will be posting an edited version online soon. Thank you very much.